Hello, I'm Allie Shansfeld, Editor-in-Chief of Orthodontic Practice US, a MedMark publication. Welcome to a live discussion and question and answer with Dr. Lisa Alvitro. In our webinar today, we'll be exploring options for aesthetic Class II correction utilizing the Forces Appliance. Before we get started, I would like to invite our viewers to use the question box in your control panel to ask any questions. Your questions will be answered at the end of the session. Now I'm pleased to introduce our guest for today, Dr. Lisa Alvitro. Dr. Alvitro is owner of Alvitro Orthodontics in Ohio and is an associate clinical professor at Case Western Reserve University. She continues to study and train her staff to stay current in the latest developments in the field of orthodontics. Her dedication to her profession has led Dr. Alvitro to become an advocate for 3M oral care, for whom she lectures extensively throughout the United States and abroad, sharing her experience and expertise. Dr. Alvitro, we turn the webinar over to you to learn more about our topic for today.
Thank you for the introduction, and good afternoon, and thank you for joining me as we explore the options for aesthetic Class II correction utilizing Forces Class II correctors. What I'd like to share with you is how you can expand your options for Class II correction. Forces is something that we've been using in our office since it was introduced to the market, and I can honestly say that it's one of our favorite things to share because it's made such a significant contribution to our patients, to our practice, and really the results that we can achieve for patients. And it's an appliance that is constantly evolving, and there's changes and modifications, and we really want to help everyone stay current with what options are out there. So Forces correctors today exist as the L-pin, the Easy-to, and now there's a wire mount option as well. I'd also like to share with you how to activate a 22mm push rod. And I want you to consider the amount of Class II correction that you can achieve. And because we're really amazed at what we're able to do, maybe things that we didn't think we were able to do 5, 10 years ago. And I also want to encourage everyone to think about how to create the optimal force vector for effective Class II correction, because Class II correction in patients is different based on what type of Class II malocclusion they have. So what are the basic components of Forces? Obviously we have our arch wires. We're going to have our headgear tube if we're going to be using an L-pin or an Easy-to module. Now we have the Forces wire mount that we don't need a headgear tube, that we can use a bonded molar, or perhaps maybe it was a patient we weren't going to use a Forces in and they have a band but there's no headgear tube. We have our push rods, which are going to activate our Forces appliance for us. And there's the universal split crimp. That's what a lot of us were used to using when we were activating our appliance when it was in place. But now there's a reactivation spacer, and you'll notice it has a little different shape. It's a complete circle, and it's really effective in activating a 22mm rod. So let's look at some of those spring options, because here's when you're starting to create really your force system. You've got the Easy-to and an occlusal tube. You've got an occlusal headgear tube with an L-pin. You've got now a wire mount, so you don't even need a band, just a really a reliable bond. And then we can also use an L-pin and a gingival tube. And I really just like to start here and everyone to kind of look at the difference. Your wire mount can give you a more vertical force vector if you need it. Your Easy module can be more horizontal. So think about not only the activation of the appliance, but really the direction. Do you need it horizontal? Do you need it more vertical? And we'll talk about what different applications for those appliances. Now, the other thing that you need to consider too is what kind of bracket system can I use Forces with. So we've got really kind of a moderate Class II relationship here. We've got a teenager. She wants straight teeth and a bigger smile. She wants to get rid of her overbite. She wants her teeth to touch, and she doesn't want braces that show. And really great option for those types of patients are Clarity Advanced. And sometimes people ask, can I use a Forces with Clarity Advanced? Yes, absolutely, you can. So our treatment option for her will be our Clarity Advanced brackets in the maxillary and the mandibular arch, and we're going to combine it with Forces Class II correctors. So we've got a bilateral Class II relationship. We've got a transverse deficiency in the maxilla and the mandible. Remember, she wanted a bigger smile, and if you really look at the angulation of the buccal segments, we need to upright those segments, and we also need to make sure that our maxillary arch has the appropriate transverse dimension when we're going into our class 2 correction. So we're going to eliminate the crowding and rotations, and don't wait for a delayed eruption of second bicuspids. We don't need all of the teeth really present to go into our forces. Now, if we take a look at the cephalometrics here, we know we've got an overjet, and we really want to try to control the position of the maxillary incisors and really correct our class 2 relationship by bringing the mandibular arch forward. So this is really the treatment effect that we're looking for. Now, the one important thing you're going to need to do to set up a forceps case is you need to establish maxillary incisor torque, and then you also want to establish the maxillary incisor position. So here we are getting ready to go into our forceps appliance. We have got our Clarity Advanced brackets, we've got our mandibular arch prepared, and we just really have the coil there to add some rigidity to where the bicuspids are still erupting. The important part is that you establish the ideal overjet that you need to be able to make that AP correction when your forceps is in place. I mentioned we're going to use that closed coil just to add some rigidity to the upper arch wire. We're also going to cinch the maxillary arch wire to limit the amount of molar distalization, and then we're going to want to cinch our lower arch. When we take a look at our forceps in place, you'll notice that it's in your mouth right now and you can't see it. So it's really a nice combination. If someone doesn't want to see brackets, they're not going to want to see elastics or any type of class 2 correction appliance. I will have to admit, though, she does have blue ties and pink ties on, so sometimes they want their braces to show, and sometimes for special events they don't. Now, if we take a look at the correction we're able to achieve, here we are with our 22 millimeter rod. We then went ahead and advanced and placed a 25 millimeter rod, and then went and allowed that to continue until we were almost to an end-to-end position there. This is usually the type of correction we're looking for, because we know when we remove that rod, there's going to be some rebound of those lower incisors. We found about 2 or 3 degrees. Part of the reason I let it in there is notice we had a space right distal or mesial to that cuspid. So we're going to go ahead and chain that lower arch and allow that rod to help push that space closed for us. Now, this was a situation that we had a 22 millimeter rod and had to activate to a 25 millimeter rod, but that's not an issue anymore, because now we have the ability to activate a 22 millimeter rod. Often if you were trying to use a universal split crimp, you'd place it on the 22 and it would want to slide down, and you'd have to stack multiple ones up. Now we simply can activate a 22 millimeter rod by using that reactivation spacer, and it will stop for us. The only difference you need to think about when you're going to be using a reactivation spacer instead of a split crimp is you have to take the rod out from the spring module. Then I like to grab these with just a ligature cutter and then position it over top of the rod, and it's a very snug fit. So you really need to line those two components up, and then you'll be able to just simply slide it down and it will stop for you. You can see here it is in place. So that's really eliminated us having to be able to, or having to change to a 25 millimeter rod like you saw previously. And also, I need to tell you that those can be used on other types, your 25s and beyond too. So really that reactivation spacer can be used with any rod, just not the 22. So we're looking at that typical that correction where we're going to go end to end. And then at the next appointment, here we're looking after we remove the rod. So from here to here, we simply remove the rod. We chain that lowers to help with that rebound, secured the upper, and then allowed everything to settle. And usually what we're going to do is take out that rigid lower arch wire and put a nickel titanium wire in to let the bite start to settle. And there we are at our finished case. We're able to see our pre-treatment and post-treatment film. And then our end result from a facial aesthetics with an increased smile. We have a nice mandibular projection. We've got lip support. So don't forget, if someone's not wanting to see their braces, a lot of times forces is really a perfect option because you're not going to see that either. What about the wire mount option? Now, this is something that's exciting and new because sometimes maybe you don't like to band. Maybe you hadn't even planned on using forces. So let's take a look at what that wire mounted option looks like. Again, you can be used with maxillary molars that are bonded. It eliminates the need for bands. Let me show you a little bit about the technique. You're going to set your lower arch up like you usually do with a forces appliance. We're going to cinch that lower arch. Now the maxillary arch wire needs to be rigid because remember the wire mount is on the arch wire itself. So we're going to want a 19 by 25 and an 022. We're going to want an 0175 by 025 in our 18 slot brackets. The one thing that we recommend when you have pins, the pins are slightly long. Because remember, they were made to go through that headgear tube. So we're going to reduce the length of those. We're then going to slide the wire mount module onto our arch wire. Now remember, they do come in two different sizes. There's an 022 and an 018. And they go on either side. You just need to make sure when you do slide it on that the headgear or the tube is toward the outside, that it's not in between the brackets. Now, if you have a convertible molar bracket, please make sure you tie that with steel because as that forces functions, it's going to place a buckle force. And if that is a convertible bracket, it could auto-convert for you. Sometimes people are unsure if their bracket is convertible or not. I always say if it has tie wings, just tie it in. Chances are it was made to be converted at some point. We also recommend steel tying the tooth anterior to the wire mount as well because remember there's going to be some force on that arch and we don't want it to pop out of the slot. A simple elastic tie can give some play in that as well. So just steel tie it and then as usual steel tie the bottom wherever the rod's going to be placed. Once you have the arch wire in place, we recommend that you use a ligature tie to go around the hook on the molar and then also around the T-bar that's on the wire mount. It's going to save it from sliding back and forth, but it also helps stabilize it when you're trying to install the appliance. Now here's a part that sometimes is confusing because if you take your ruler that you have from your old forces kits, if it's an easy module or L pin, what you're seeing on that ruler is actually a picture of the bracket. You need to line that up with the wire mount, not the bracket. If you line it up with the bracket, you're going to end up overactive. So put the distal behind the wire mount and then measure. And then you'll end up with the right size. And remember, the number that appears on the ruler actually includes the activation. Do not add to that. So we're going to insert the pin through the distal, and it's much easier if you've cut those pins smaller. We're then going to just turn that up, and I like to use a jar back, and I'll turn it into a circle. So now that's really our completed installation. We'll slide the rod in and cinch it. Now you're going to have to consider your rod location because remember you are mounted anterior to the molar and that's different than when you're using a headgear tube. This now makes it's a shorter distance between the mesial of the molar and either the cuspid or the bi. So you're going to have to look at where do you want that to be located. A lot of us that use forces behind the bicuspid do that to help control the lower incisors, but you can use it to the cuspid with your wire mount and you still have a short distance. So you don't tend to see as much of that rolling that we would see when we were using a longer rod. But sometimes people forget that it can affect not only the activation, but how vertical that is placed. So let's just take a look at the case where we've got a wire mounted forces in place. And again, this is going to be a nice case. We're going to need some vertical control. We've got a class 2 relationship. We've got an overbite, an open bite tendency. We want to increase really incisor display for him and create a better smile line. At the same time, we're going to utilize our wire-mounted forces. And, a lot of our patients in this age group are kids that I want to have control of the case because I'm pretty sure I can't trust them to be compliant with other types of appliances. So we just have a mild class 2 relationship, but we do have that vertical growth pattern. Here we are with our forces in place. You can see we started at the cuspid, then as we advanced forward, we moved it back to the bicuspid. You can see the yellow tie that was holding that module and securing it. We also have the upper arch chain to help reduce the amount of molar distalization, and that lower arch is cinched. So, evaluate. You may start at the cuspid and move to the bi. And this is the part I think where people tend to overlook with forces. We really tend to focus on the right activation, but we forget wherever we put the rod dictates how much of that force is dissipated in a horizontal direction and how much of it is dissipated in a vertical direction. So just really with the wire mount, you have to remember you are anterior to that molar. So you may have a more vertical. Now, if someone has an open bite tendency and a vertical growth pattern, this may be exactly what you want. But if they're deep and have more decreased lower face height, you maybe want to start at that cuspid or keep it there. You want to watch overactivation too. Remember, if you have a patient bite down and you see the rod coming out the back, you're overactivating the appliance. And overactivation can lead to those lower incisor proclination, or overactivation can roll your molars out. So the activation is just as important than the direction of the force as well. Now, what if you like the angle, but you think maybe I'm just a little bit overactive? The thing that's really convenient with a wire mount is, since you have that pin, you can pull the pin out and kind of almost create like a half size. It's not as active than if you would pull that tighter, you'd be compressing that more. And the nice thing about it is there's a molar bond right there. So the patient's not really going to know that's there. When you try to do this trick when you're hanging off of a headgear tube, it's out the back. It can be in their cheek. This way it lays really close to that bracket, so they're not going to feel that. And you can see that's one of the things that we were doing with this patient here too, is I wanted that vertical nature, but we were going to be a little bit overactive, so I just pulled that pin out the back a little bit to give a little bit more play and avoid overactivation. Oh, let me show you too. The other thing that you could do with that, if you needed to change the angle, remember you're allowed to bend that up, or you can bend that down to change that angulation. And with there being a bracket right there, it's more stable than when you try to do it with just a headgear tube off of a band. So here we are, we removed our forces. And then we'll go into our finished case. What about a wire-mounted forces for patients who are not initially planned for forces correction? Kind of a mild malocclusion. We're going to create space for the arch, and looking at the beginning, we do have a midline deviation, and it's coming from the mandibular arch. Our maxillary midline's pretty much on, and you line the dentition. You're getting close. All you need is to correct the midline, and you just can't get there. Sometimes midlines are hard, I think, with elastics, and sometimes it's hard to motivate patients. So, before I would try to really motivate the patient, because I didn't want to have to pull off a band that didn't have a headgear tube, put a new band on, maybe go back an arch wire size. So we would try all kind of things, try to motivate them, bribe them. Now with a wire mount, if someone doesn't wear their elastics the first time, we can put a wire mount on because we're not wasting any time, we're not losing any time. I'm just saying, we'll go ahead and do it right at that appointment, because for some reason I thought that if someone doesn't wear them the first time, if I ask them, they'll wear it the second or third or fourth or fifth time. No, if they're going to do it the first time, great. If they're not, just put a wire mount on, keep going, and you're not having to waste any time. And really everything that we talked about applies. You're just running it off of, you're still off the arch wire. You just happen to have a band behind there instead of a bond. And what's interesting, if you look at the midline correction, it's not a big midline correction that we need, but if you're not going to get there, you're really kind of stuck. We put her wire-mounted forces on. Here she came back in one appointment, and we've got it. So, don't forget about this option. This is something that has been really valuable for us. Let's talk about the consideration. How much class 2 correction can you achieve? Just going to look at a patient that came back and is part of our retention study, and this obviously is our pre-treatment facial pictures, and then we've got our pre-treatment malocclusion. So he's got a significant malocclusion. He's deep. He's also quite mandibular retrognathic, and sometimes people say, what would you use on that? Can you use the forces? Yeah, we did, and I'll show you how we did that. But the thing you need to keep in mind, sometimes people will think, well, if I've got a further distance to go, I need to activate my appliance more. No, what you need to think of is set up the force system you want. Is it horizontal? Is it vertical? Use the ideal activation, secure your arch wires, just keep it in longer. For some reason, people think, well, you only get to wear forces for 6 months. If I have further to go, I need to overactivate it. And what's going to happen if you overactivate? Your lower incisors will start to dump, your maxillary molars will roll, and your upper incisors will start to retrocline and you'll lose torque. So if we take a look at where we're able to achieve, and now this young man's in part of our retention study, you're able to see we could make some significant facial changes. And now if we go ahead and look forward to our malocclusion, over time he's starting to deepen up just a little bit. But if we compare, let's look at those films. That's a significant A and B difference. We really wanted to increase mandibular projection. But look, he wore his forces for 12 months. And that was something for me too. I always thought, if I have to go further, I have to activate more. No, I just have to be patient. I just have to wear the appliance longer so that I can achieve the result that I want. So keep that in mind when you're treatment planning something that's a little bit more complex or maybe a little bit more class 2, that yes, you can get significant results with forces, but you may have to leave that in longer. So let's take a look about some of the things I think about when I'm treatment planning a more significant class 2 relationship. We need to think about the AP difference we want to correct. We also need to take a look at the transverse dimension. That's something that sometimes is overlooked. And if you don't have the correct transverse dimension, when you place forces, it's not going to lay at the right angle. And again, too, that's where sometimes people see, or myself too, I'll see unusual effects in the maxilla, and it's because I didn't have the maxillary arch width set up. So that take a patient that's class 2, position them into class 1, and see, do I have enough transverse dimension? If I don't, I need to establish that before you try a class 2 correction so that you can get the optimal results. So we'll correct that transverse, and often for us it's including an RPE. So we'll use a rapid expansion appliance, run off the first molars as we have our fixed appliances in place. Obviously, we want to align the dentition. I want to eliminate the overjet and the overbite. Our other treatment objective, we want to correct the anterior-posterior discrepancy, increase mandibular projection, and then improve facial aesthetics. And we look at our pre-forces setup. So we've got a significant overjet, but let's think about what's going to make this successful. First, that maxillary mandibular arch preparation, having that maxillary transverse dimension, making sure that that lower arch is prepared and that lower arch is secured by cinching it, tying it back, however you like to do that. And you don't have to worry so much about bite opening. If you take a look, you'll see he's still pretty deep, but the rod alone is going to help intrude those lower incisors, about 2.5 millimeters. If you need more than that, go ahead and sweep some bite opening curve into that lower arch when you are placing your forces. Now, controlling the mandibular incisors is going to be very important too for success, because we want to maintain them in an upright position. Best way to control lower incisors: cinch the lower arch, put some negative torque in your wire or in the brackets, and don't overactivate. And I know I sound like I keep talking about that, but I used to overactivate all the time. And as I learned to be patient, as I learned to watch that, I really saw my results start to improve. Think about the rod location too. Where are you going to place the rod? You can go to the cuspid, you can go to a bicuspid. Bicuspids a lot of times will give you more lower incisor control, but it might be too vertical. You can change it throughout treatment. You can start at the cuspid, go to the bi, or sometimes if we see too much vertical, I'll take it off the bi, put it back to the cuspid. So think about that. Look at that proper activation and how long forces is going to be in place. So I mentioned really cinch that lower arch wire. Just don't put your pliers in and turn it. We'll go behind the wire in between the wings and we'll squeeze. Either cinch the upper arch, chain it, or you can even do both if you'd like, if you're really trying to maintain that arch as one unit. We looked at that bicuspid location to reduce those lower incisor proclination. And like we mentioned with the wire mount, look where you're positioning that ruler, but also make sure that your patients are biting in centric relation or centric occlusion, because that's often a common misconception too, that people feel that they have to position into a class 1 to measure. Actually, what it is you got to be in that centric relation or centric occlusion as you measure. When the patient bites in the centric relation or centric occlusion, you should see about 2 millimeters behind the stop on the rod or the curve if you're at a 22. You should be able to completely compress that spring. If you're seeing the rod come out the back, that's overactive. Here's the more correct appearance of activation. If it's overactive, it'll look like a rod and it'll swing out to the side. So we really want to avoid that overactivation. Here we are with our post forces correction. We can see the significant change we're able to, and I think really, pretty well control those upper and lower incisors by using the correct activation. There we are at debond day. It's just so exciting to look at the difference for him. He's such a nice young man, and we were just talking to his grandma earlier, because we've got a brother working with as well. So here we are from our initial to our debond, and I'm not sure I would have been comfortable using a forces before I understood the proper activation and the amount of incisor control and amount of correction that I could get. So just really, consider your options when you're creating that effective force system. We've got so many options now, occlusal tubes, we've got wire mounts, we can use them and place the rods at different brackets, cuspids, bicuspids. We can put omega loops on wires, crimps on wires. We can use them with our aesthetic brackets. I mean, there are just a lot of options that I wanted to share and kind of give you some things to think about as your treatment planning cases, and what you can offer patients, and really what can differentiate your practice and set it apart, and just really do some exciting things for patients that will make other people notice and want to be your patients as well. So I thank you for your attention. I hope you found some useful information, and now we're going to head back onto our question and answer period.
Thank you, Dr. Alvitra. That was A really, really good presentation. I have some questions, but before I get into those, I'd like to invite viewers to use the question box in the control panel to ask any questions that you might have. Our first question that we got in today was, do you always set up your push rod between the 4s and 5s instead of between the 3s and 4s?
No, I don't. And it really depends on how we want the force system to be developed. Often we will go behind the first bicuspid. Sometimes we will, in our more significant class 2 malocclusions, we may start at the cuspid and move. We need to first look at the activation. Sometimes behind a first bicuspid, a 22 would be overactive. So check your activation and then really look at when you're placing the rod, is it going to be too vertical? And do you need it more horizontal? So there really is, we use both of those locations as we're setting up our force system.
Okay, our next question. When would you use an omega loop on the arch wire?
A way you can use an omega loop on the arch wire is that if you really need to establish a more vertical force system, by dropping that loop in, you can really create something that's very vertical. Maybe you've got someone who's got an open bite and you want to rotate their maxillary occlusal plane through posterior intrusion and the maxillary incisors coming forward. Or you may have someone that is so class 2 or young enough that even the smallest rod is too active. So you can use an omega loop to increase the length. You can use an omega loop to create a more vertical force system, or you can even use an omega loop if you don't have all of the teeth bracketed, or if you, for some particular reason, do not want to have a push rod against a bicuspid or a cuspid. Oh, and to do that, make sure that you have, obviously a rigid wire. You're going to have a steel wire placed. And probably the trickiest part about bending those omega loops is making sure that as you're bending it, you're not distorting the arch and changing the torque anterior to that loop.
Okay, our next question. What do I need to consider when installing a forceps wire mount?
Things that you're going to need to consider is, one, do you have the maxillary arch aligned, and do you have the transverse dimension that you need? Also, are you in a rigid wire that's going to be able to support that? Often in a ligated bracket, you're going to have a steel wire, and you want it to be a full-size wire. You can't run these off of light wires. You can't run these off of night-high wires because the force is going to be onto the wire itself. The other thing to consider, too, is how you're going to secure that arch wire. Are you going to cinch it distal to the molars? Are you going to tie it back? The thing that you have to remember is, that module is on the wire. If you were just to place and not try to secure the molar at all and just to really start to do a lot of distalization, be careful that you don't fall off the edge of your arch wire, because now that wire mount is attached to that. So just really some of the main considerations is what's going on with the maxillary arch wire.
Okay. For more severe cases, do the 7s have to be erupted and bonded?
Okay. It really depends. What about second molars? And to me, the rule of thumb that we use in our office, if somebody has an increased lower face height, if they have an open bite tendency, or a vertical growth pattern, I want to include second molars, because part of my treatment objective is to intrude the posterior molars, kind of like a posterior hypoheadgear effect. So if I need to control the posterior vertical, I have to have my second molars bonded if they're erupted. Now it's the opposite. If somebody is deep, has a decreased lower face height, and I don't want any posterior intrusion, I'm going to purposely stay off the second molars. That way they can act as my posterior vertical stops. So for me, second molars are included in my forces setup if they're open, increased lower face height, vertical growth pattern. If they're deep, have a decreased lower face height, I stay off of them.
Okay. How do I choose what wires to use, and how am I going to set up the case prior to installation of the forceps appliance?
As far as wire selection, obviously some of it depends if you're working on an 022 slot or an 018 slot, and it really depends what type of forces appliance you're going to be using. Now, if you think about your lower arch, you're going to need something we usually recommend either a steel or a beta wire, because the rod rests on the wire. You can't run them on the lower arch, cannot be a thin wire, cannot be a flexible wire. So we're going to want to be into that rectangular wire in the lower arch. The upper arch, we're again going to want to be usually in a rectangular wire. We're going to have the transverse set, rotations eliminated. And if we're going to be using a wire mount, it needs to be more rigid, because again, the wire mount is resting on the arch wire itself. If I'm going to be using I got one that's running off of a headgear tube, if it's a wire, an easy module or an L pin, I have some flexibility. I may choose to use a rectangular wire that's a NiTi wire, not a steel or a beta wire. So it really kind of depends what kind of what system you're going to be using. Just the key point is, if you're using a wire mount, the mount itself is on the wire, and that's where the force is. The lower, the rod is always on the wire, so again, that's where the force is going to be. So we need to have a wire that's stiff enough so that it can support that force and not deflect the wire.
Okay. What tips do you have for making installation of any type of forces appliance easier?
One of the biggest tips that we found is get your wires set first. I used to get so excited that we're going to start getting rid of your overjet, or I'd say overbite, obviously the patients, that I'd put their wires in and put their forces in all at the same appointment. And those longer appointments, patients tend to get concerned because they know they're going to be here longer. One of the easiest things to do is put your wires in first, get the wires set. Send your patients away for 2 weeks, 4 weeks, till you know those wires are passive, and then put your forces in. And the thing is, you can put a forces in quicker than you can teach a kid to put their own rubber bands on. And the thing is, what is probably the most uncomfortable part are the wires, not the springs. And most kids, when you put the springs in, they're like, okay, that was it. Now those wires last time, that was a bigger deal. So you may want to try splitting those appointments up. Also, some other tips, and a lot of this is patient motivation. We start talking about forces from the very beginning. Just did some consultations today. It's like, we used to make kids wear headgear, and now you don't have to wear headgear. You get to wear springs. And we start talking about it from the very beginning. Braces will line up your teeth, your springs will fix your bite, and then you get your braces off. So they almost start looking forward to, when do I get to that part, because they know that's the next step. The other thing, too, is to make sure you have a model chair side that patients can play with, so they understand, how this works, and also give them some goals. Okay, we like to take photographs, and we're also taking films, because a lot of them are used for studies, to show people, oh my gosh, this is what your overbite was. I bet the next time you come back, it's going to be less, and you can keep comparing that. I've even gotten into some bets with people. It's like, okay, if young man is like, I'm not wearing these. I'm like, well, if you come back and your overbite is not less, next time we'll take them off and I'll give you a gift card. Well, what was going to happen. He came back and it was less. He's like, all right, I see. And I said, was it very hard? He goes, no. Because the thing is, particularly if you install them with the right activation, particularly if you're behind a bicuspid, you can't see it. It really pretty much auto-corrects. They just have to be, careful with it. Not any more careful than they are with braces. When people ask, do anyone ever have a hard time getting adjusted to them? Yeah, but those are the kids that have a hard time getting used to adjusted to braces as well. So you can pretty much predict that. I think where it gets a little trickier is when people were using them kind of punitive, like, well, you didn't do this, now I'm going to make you do that, instead of it being part of the plan all along. Sorry.
Oh, no, my question is related to that, is how do I increase patient acceptance and comfort when using the forces appliance? So that's kind of related to what you just discussed.
Yeah, and that's really one of the big things. If, when you overactivate the appliance and it starts to roll out to the side, that can be uncomfortable. But if you really watch your activation, you can keep them in nice and close. With a wire mount, too, you've got a smaller span, so that sometimes is much more comfortable for patients. When you've got a larger distance and you're trying to go to the cuspid. But if you can eliminate that rolling, that's where a lot of the patients would say, okay, I didn't like that, that was uncomfortable. And so it's the activation, it's really where you're placing it, it's preparation of the patient that will make compliance and make their acceptance so much easier.
Okay, next one's a three-part question.
Okay.
What are the most common clinical complications? How do I avoid them? How do I correct them?
Perfect. Okay, probably the biggest complication, and I would know because I've seen them, is when loss of control of your lower incisors and loss of control of the upper incisors, where you start to see the upper incisors start to kind of retrocline, or you see particularly lower incisors start to flare, or you see spacing in the lower arch. Now, those flaring of the lower incisors and the spacing in the lower arch can come from a couple places. One, maybe you didn't cinch the arch wire well enough, or maybe you overactivated the appliance. The upper, too, when you start to see a loss of that torque, when the upper incisors start to tip back, there may be it could be overactive, or it could be too much resistance. Maybe I have the wire cinched or chained and I should unchain it. And the other that relates to that overactivation is when the molars start to roll out. So if I see lower incisors start to procline, if I start to see molars start to roll out, one of the first things I need to do is check that appliance and make sure it's not overactive. And if it is, I want to decrease that activation. Now, if you see significant lower incisor proclination, you may want to take that appliance off and just let it rebound. The one thing I found myself is when I take a forceps out, get rid of the rigid wires, put a more flexible wire, like a night tie wire. It can still be rectangular, and let things start to rebound. Sometimes people get really concerned about those lower incisors, but part of it, they'll rebound some just when you take the rod out. But if you find that you're proclining too much, just take that rod out, go back and maybe chain molar to molar to recover those lower incisors, and then put the appliance back in. Now, it takes a little planning on the front end, too, because you have to think about, from the beginning of the case, where do you want your lower incisors when you go into your forceps? So you may have to upright them to be able to control them. So your biggest clinical complication really comes from overactivation, or not having a transverse dimension, too, because what happens is if you're too narrow on the top, you put your forceps in and it's at an unusual angle. And as it starts to roll out to the side, it can start to roll your molars. But I always tell people, don't panic, because if ever you've seen anything really weird happen with your forceps, take it out, put some night tie wires in, take a deep breath, and let the patient go away. And you'll be surprised 6 weeks later how much of that recovers, because what you've done is you've removed that the force, the contraindicated force. You may choose at that time to go back into your forceps appliance. One other complication you can see clinically is that you may have a bracket become debonded when the forceps is in place. I used to take everything off, put them all back together, but now I don't. If you see a bicuspid or a cuspid that's pushing, that the rod is maybe pushed off, what you can simply do is remove that bracket and put a crimp stop on the rod, or even just take that bracket and we'll kind of squeeze it down and make it its own stop. You can pick up broken brackets later, but once you get the forceps in, keep going. And so that was kind of another clinical complication that sometimes would bog us down, because I'd take everything out, put everything back on, and start that over. But just keep going. And you know, some of these kids, their biggest issue is that overjet. You gotta get them to class 1, and then you can line up any teeth that are maybe you've seen some movement, that some rolling, or maybe a lost bracket throughout forceps.
Okay, our last question that we have time for today is, how long do I leave the forceps appliance in place?
Good question. How long would I leave it? Well, it kind of depends first how far you have to go. The average forceps patient probably has an appliance in about 6 months. It's about active 4. Just your standard class 2 correction. You place the rod, you get that 2 millimeters, you activate it, you're usually there, and then I'll keep it there in that inactive state for 1 appointment interval. So most of them have them completely out of their mouth in 6 months. Now, some of the more significant full step class 2 or maybe severely retrognathic, those kids will have those appliances in for up to even 11, 12 months. Or sometimes if you're going through an asymmetry, that's maybe a mandibular skeletal asymmetry. And or if you're using them in a non-growing patient, and those are those 25-year-olds, the 30-year-olds, they're going to have them in longer too. because you're not going to get that same treatment response. That when you place a forces during peak growth, you're going to see an accelerated response. And it was in an article that was published using our cases in Angle probably about 2 years ago by Dr. Savello and Fallis. So if you're using it past peak growth or you're using it in adults, they're going to wear it longer. So your standard adolescent, about 6 months. More significant, you may be going to that 8, 10, 12-month period. Adults, you're probably looking closer to about a 7 to 8 month period.
Okay, I know I said that was the last question, but we did get a quick one.
Okay.
Have you considered sliding easy clips for the upper wire?
Pardon, can you repeat that?
Have you considered sliding easy clips for the upper wire?
I'm not sure. I'm trying to think what that would be. A sliding easy clip for the upper wire. I'm sorry, I'm having. I'm not sure I completely understand that.
You can we can email that person. And,
okay, that'd be perfect. Yep.
You know, but that's our last question for today.
Okay. All right, thank you.
And I wanted to thank you for a wonderful presentation and thank everyone for your questions. But we have run out of time for today. As a special gift for viewers, 3M is giving out 2 free complete cases of the Aesthetic Class 2 correction system. Make sure to visit 3m.com/aesthetics for your free cases or call 1-800-423-4588. That's 1-800-423-4588. This information will appear in your control panel chat box along with a handout for more information about the Forces Appliance. Following the webinar, we'll send you a recording of the presentation, and we thank you all for attending. And again, we thank Dr. Albitro for your wonderful presentation.
Well, thank you. I hope you found it useful.
Thank you. Good night.
Thanks. Bye-bye.